Okay, so let's move on to chapter 183, shock states. So first, a definition. Shock is defined by decreased perfusion to tissues resulting in injury to the cells. There is a known mismatch between O2 delivery and O2 demand. And ultimately, inflammatory markers are released that further hinder tissue perfusion. And it really is thought that it's the inflammatory markers that result in organ failure or death if not immediately rectified. So let's walk through quickly the four types of shock. You've seen these before. Remember, hypovolemic, one that we're very well accustomed to in the operating room, with the most common of which is hemorrhagic shock, and that's an insufficient circulating blood volume. Cardiogenic, mechanical failure of the ventricles of the heart. Obstructive, which is hindrance of flow in the circulation, leading to an increase in afterload or a decrease in diastolic filling. Remember the normal circulating volume and myocardial function here. And the most common examples are tamponade and PE. Distributive shock, which is vasodilation leading to a drop in preload, resulting in hypotension and normal or increased cardiac output. And of course, the most common example that we routinely see is septic shock, but don't forget about anaphylactic shock and neurogenic shock. So again, manifestations of shock, hypoxia and anaerobic metabolism, a depletion of ATP stores and acidosis with buildup of lactate. And again, it's the inflammatory mediators that are released here that really produce direct cellular injury. The body begins to compensate with stimulation of the sympathetic nervous system, improving extraction of oxygen, and a release of catecholamines. So this is a great chart I pulled straight out of your chapter, and it does a good job of just breaking down the different aspects of the four types of shock. So here's your hypovolemic. Remember, it's a low circulating blood volume, so you expect your CVP to be low, your wedge to be low. Remember, your wedge is a reflection of your left ventricular filling pressure, okay? So you would expect that to be low. Of course, your cardiac output low, and your SVR is high. And your SVR is high because catecholamines are being released in an effort to bring up the preload and bring up the cardiac output. Cardiogenic shock, remember the heart's not working there. So your CVP is going to be high, your wedge is going to be high, your left ventricular filling pressure, again, is going to be high. Cardiac output's going to be low. And again, your SVR is going to be high. Those catecholamines, again, are being released to bring up that cardiac output. Obstructive shock, remember your CVP is elevated here. Cardiac output, though, is going to be low. And again, catecholamines are being released. SVR is high. Your distributive shock, CVP is going to be low. Your CVP is going to be low because of that vasodilation that you're getting. As a result, your left ventricular filling pressure or your wedge is going to be low. Cardiac output, though, is generally high. And again, SVR is low. All right, let's talk about SIRS. A lot of attention has been, paid to this in the last 40 years or so. Based on the 1991 definition of SIRS, which is really what we still use, I just kind of wanted to walk you through what the definition is. The whole idea of identifying a patient with SIRS is to then hopefully intervene earlier and improve morbidity and mortality. Okay, so let's talk again. Let's go back here and talk about the criteria that leads to the SIRS diagnosis. So you need two of the four following criteria. So temperature greater than 38 or less than 36, heart rate greater than 90, hyperventilation with respiratory rate greater than 20 or arterial CO2 less than 32, white blood cells greater than 12,000 or less than 4,000. Okay, so you need two of these to meet SIRS. Sepsis is SIRS plus a source of infection. Severe sepsis is organ dysfunction plus sepsis. Refractory hypotension that does not respond to fluids is termed septic shock. And again, that's your systolic greater less than 90 and MAP less than 70. So it's really worth your while to sit down and go over these definitions. They seem like low-hanging fruit for test questions. So again, sepsis is associated with a very high mortality rate. In the past, gram-negative organisms were thought to be the culprit, but in the last 10 years or so, it's been recognized more and more that gram-positive organisms are probably accountable for a number of cases as well. The most common site of infection is respiratory. After that is GU, skin, soft tissue, and CNS. So treatment of sepsis, and I'm sure you've heard of the Surviving Sepsis campaign at this point. And guidelines that have been put out a number of different years. The most recent version we have now is from 2012. And the whole idea is to get patients early and aggressive therapy. So within 6 hours, antibiotics and fluid resuscitation. And the fluid resuscitation can have very specific goals, be it old school with CVP. Now it might be pulse pressure variation and urine output. Another part of early goal-directed therapy is vasopressors. And generally they were started if fluid resuscitation did not yield a MAP greater than 65. Blood transfusions were considered if needed. And again, we've shown in a number of studies that patients in the goal-directed group had significant decrease in morbidity and mortality when compared to the control groups. The PROCESS trial, which is the protocolized care for early septic shock that was published in 2014, really reiterated this, again, with early antibiotics and fluid resuscitation. So again, Surviving Sepsis campaign guidelines is something you really should know and again, it's essentially early goal-directed therapy. And then again, the PROCESS trial in 2014, which really showed a reduction in morbidity and mortality with early treatment with antibiotics and fluid resuscitation. Vasopressor therapy for sepsis, we're very familiar with norepi and vasopressin. Another trial to potentially be familiar with is the VAST trial, which really showed no improvement in 28-day mortality in the use of vasopressin compared to norepi. However, I think everyone appreciates the added use of vasopressin, given that it's a different receptor than norepi. And so using it as an adjunct is pretty well accepted now. So multiple organ dysfunction syndrome, again, it really is the inflammation that occurs from sepsis that's really thought to be what's so deleterious to organs that ultimately cause their dysfunction. You should be familiar with the MODS score, and the MODS score is calculated by the degree of dysfunction of a number of different organs. Respiratory, renal, hepatobiliary, cardiovascular, hematologic, and CNS. And of course, the higher the MODS score, the poorer the prognosis is. Okay, question. Which of the following statements about the use of IV hydrocortisone in adult patients with septic shock is most likely true? Let's see, should be administered to patients with sepsis to reduce the risk of developing septic shock, should not be administered unless random cortisol levels show relative adrenal insufficiency, should not be administered to patients with septic shock, or should not be administered to patients with septic shock or responsive to vasopressors. So this is part of the Surviving Sepsis campaign, and the answer is D. They should not be administered with septic shock responsive to vasopressors. All right, let's go on to the next question. A 55-year-old man, chronic smoker with a history of CADs, admitted to the hospital with hemoptysis and shortness of breath. During his stay, he develops a blood pressure of 80/40, which is intractable to fluid resuscitation. His cardiac output is estimated to be 9. What is the most likely cause of his hypotension? So let's see. So I think what you really need to know here is obviously the blood pressure is low. He's not responding to fluid resuscitation, and his cardiac output is high. All right, so you're thinking about sepsis, right? And again, the most common cause of infection in patients is one of the respiratory tree. So the most likely cause of his hypotension is C, pneumonia. He's not really showing evidence of hemorrhage, not necessarily of myocardial infarction or pulmonary embolism. Again, PE and MI both would have, all three of these actually would have a low cardiac output. Okay, we're going to stop there.